Hi all, welcome to Ranjit Anesthesia Academy. Today we are going to deal with one important physiological topic which is very important in perioperative outcome. That is nothing but coronary circulation. Why we have to know about coronary circulation? We all know that coronary artery disease is one of the most common disease which affects the outcome in the perioperative period. And not only that, it accounts for 1/3 of the perioperative mortality. So, knowledge of coronary circulation is must for all anesthesiologists. The problem is like tip of iceberg. Here you can see 1/3 of the patient have cardiac disease, that is true. But what is happening is there is 9-fold increase in mortality, 32-fold increase in morbidity. The cardiac outcome is bad by almost 47%, poor long-term prognosis, and most importantly, your cost escalates by around 50%. Coronary circulation is quite unique in a way. How? The heart normally beats about 1 lakh times per day and it pumps about 8,000 liters in a day. So, this two major function requires lot of energy, and anatomically it supplies blood to the conduction system, your valves, your chamber, all the major walls like anterior wall, posterior wall, lateral wall and the septal wall. 2 septums, atrial septum, ventricular septum, and there are about 16 to 17 subsegments in the myocardium and 3 layers, epicardium, pericardium and myocardium, and heart gives rise to 2 great arteries and it receives blood from 2 great veins. Everything requires coronary circulation. So, let me start on an interesting note. Here you can see 2 great cricket legends are doing their practice. Okay, one is Sachin Tendulkar and another is Kapil Dev. Both are legends on their own way. And see what they have to say about an energy drink.
Boost is the secret of my energy.
Our energy.
So if heart has a voice, definitely it will say coronary circulation is the secret of my energy. But coronary circulation does not provide energy only to the heart. If heart is okay only, the whole body gets the energy. So, coronary circulation is a secret of both heart circulation as well as the entire circulation of the body. So, with this background, in the next another 25 to 30 minutes, I will be briefly outlining about some major events of coronary arteries in the history, anatomy and course and supply of the coronary artery, physiological application of the coronary circulation which is quite complex but very interesting, and various abnormalities of the coronary circulation and clinical application in the perioperative period. Now let us come to the history of coronary arteries. Everybody thinks that coronary artery disease is a disease of urbanization, but in this post-mortem which was done in 16 mummies, 9 of the 16 mummies, this post-mortem was done in 2000, they showed that out of 16 mummies, 9 had coronary artery disease. This was a CT scan of the mummies. All of them had some calcium or some disease of the coronary arteries. So, coronary artery disease is age old like mummies. Then in the 14th century, okay, when actually we don't know when the coronary artery disease came into existence, but it was Leonardo da Vinci in his book Renaissance. He has drawn a diagram of something like lines inside the heart, which was nothing but the coronary artery. So, he was the first to describe about coronary arteries in the 14th century. Then it was left to William Harvey in the 15th century, who was called the father of circulation. He said that blood moves around the body in a circulatory manner from the heart. Okay, blood come inside and go outside from the heart. But he has also shown the 3 lines which are nothing but the coronary arteries. And he made an important statement, life of flesh is in the blood. So, you require some form of blood supply to all organ to survive. So, life depends upon the blood. So, heart also has to receive the blood supply. That was the bottom of the William Harvey's physiology of heart. Then it was left to Frederick Hoffman. He said that coronary artery disease is nothing but reduced passage of blood in coronary arteries. Okay. Then William Heberden said that in the 17th century, he said that it will cause an harmless conditions like he stopped short of mentioning of angina, but he put it as an disagreeable sensation which happens due to reduced blood supply in the heart. The term angina was coined by William Osler in the 18th century, where he did a lot of research on coronary artery disease and gave a lot of lectures on angina pectoris. So far we were looking about the coronary artery disease, but we didn't have any anatomical imaging. So it was left to Higgins Moniz and Werner Frostman. He did angiogram on himself. Okay, both got Nobel Prize for angiogram, but they couldn't do coronary angiogram, but they found out angiogram of the blood vessels can be done. But it was left to Mason-Jones in 1958, and this was the first coronary angiogram where you can see the right, left and the left circumflex artery. This was the first coronary angiogram. But now we have CT angiogram where you can see the course of the blood vessels along the various part of the heart structures. The next step is going to be nuclear imaging and PET scan, where they show the metabolism of the heart muscles as well as individual supply to each muscle and what is the oxygen supply and demand. Those things also can be found out in the recent nuclear imaging. Now let us move to anatomy of coronary arteries. So there are two coronary artery. One is the left coronary artery and another is the right coronary artery. Okay, this left coronary artery arises from the ascending aorta across the aortic sinus. This is the left aortic sinus and this is the right aortic sinus. The left comes from the left aortic sinus and the right coronary artery comes from the right aortic sinus. From there, you can see the left coronary artery. Okay, this is the aorta, this is the left atrium and this is the left ventricle, this is the right ventricle and this is the right atrium, and here you have PA. So the left coronary artery, which is the left main coronary artery, comes from the left coronary sinus between the left atrium and the pulmonary artery. Then it divides into two branches. Here you have the LAD and here you have the circumflex. Okay, and you can see the right coronary artery comes from the right coronary sinus between the right atrium and the right ventricle. If you look from the superior surface, this is the aorta, this is the pulmonary artery and this is the left main coming from the aorta, and you have the left atrium and left ventricle, and you can see the circumflex going in the left crux. The crux is between the left atrium and the left ventricle, and here you can see the obtuse marginal artery supplying the lateral part of the left ventricle. If you look at the lateral surface, you can see the obtuse marginal vessel and you can see the circumflex going between in the left crux between the left atrium and the left ventricle. And if you look at the arterial surface, here you can see the left anterior descending artery descending in the interventricular groove between the right ventricle and the left ventricle. And if you look at the posterior surface, here you can see the right coronary artery in the posterior interventricular groove between the right ventricle and the left ventricle. This is the left ventricle, this is the right ventricle. So you have the left main coming between the pulmonary artery and the left atrium. This is the circumflex, this is the left anterior descending, and this is the left crux. Here the circumflex runs into it. Now you can see the left anterior descending running in the interventricular groove. This is the left ventricle, this is the right ventricle. This is the left anterior descending artery. And you can see that it goes and supplies the anterior 2/3 of the septum and the anterior papillary muscle and whole of left ventricle. This is the supply of left anterior descending. Then you can see the circumflex running in the left crux between the left atrium and left ventricle. This is and goes posteriorly into the interventricular groove, and before going that it supplies the left atrium and the lateral ventricle. Left atrium and lateral ventricle are supplied by the circumflex. And the right coronary, it comes between the right atrium and the right ventricle, right coronary sulcus, before it gives a branch to the SA node. Then as marginal, it supplies the acute marginal arteries, it supplies the right ventricle, full of right ventricle. Then it goes into the as posterior descending artery into the posterior interventricular groove. Here you can see it runs in the posterior interventricular groove and supply the posterior ventricle and supply the posterior part of the septum and posterior papillary muscle and the posterior part of the left ventricle. So, these are the major causes of the right and left coronary artery and its supply. Here from the surgical point of view, this is the LAD and this is the diagonal and this is the left atrium. Here you can see the LAD and this is the diagonal. And here you can see the left atrium here and you can see the circumflex continuing as marginal, obtuse marginal. And this is the right coronary artery running between the right atrium and right ventricle and going into the posterior interventricular groove. This is the right ventricle, this is the left ventricle and this is the posterior descending artery. And angiographically, this is the LAD along with the septal and this lateral part is the circumflex. And here you can see the right coronary artery which is like a C shape which goes like posterior descending and the posterolateral artery. This is the angiographic view. So, we have an illustrated picture of how the coronary supply runs. You have the CT images, you have the coronary images and we can visualize directly the coronary artery. So, what is the bottom line of this anatomy? You have to know the supply of this three major vessels with regard to right ventricle and the left ventricle. This is the left anterior descending artery. It supplied the anterior 2/3 of the septum and the anterior wall of the left ventricle. Your circumflex supply the lateral part of the left ventricle and your right coronary supplies the right ventricle, posterior part of the septum and posterior part of the left ventricle. So, these are the three major supply of the three major coronary artery which is reflected in the electrocardiogram. For example, if you take the LAD, you can see the anterior lead V2, V3 and V4. If you have a lesion in the circumflex, it is the lateral wall which is affected which can be reflected in V5, V6, lead 1 and AVL. And if you have the right coronary which is affected, you have the whole of right ventricle and the posterior part of the ventricle which is affected. So, you have lead 2, 3, AVF and V1. So, if a lesion in the particular vessel is there, this ECG is very important in diagnosing the coronary artery disease. So far, we are looking at artery and the external aspect. What happens on the luminal aspects? So, coronary artery as any other arteries have three major layers. Intima is the interlayer, media is the middle layer and adventitia. This is the adventitia which is the outermost layer. The intima with the endothelium and the subendothelial connective tissue plays a major role in controlling the vasomotor tone. And it is separated from the media by internal elastic membrane and it is separated from the adventitia. The media is separated from the adventitia with the external elastic membrane and there is lot of smooth muscles and collagen in the media. And the adventitia has lot of fibronectin and it plays a major role in fibrosis. This is the inner part of the coronary artery. Why you have to know about this inner part? Okay, let me explain how a coronary artery disease develops. Okay, this is the short axis view where you can see the entire lumen of the coronary artery. This is the lumen in the long axis. This is the normal coronary artery. So, the first step in developing a coronary artery disease is your fatty deposit between the intima and the media. This is called the fatty streaks. Next, as the calcium gets deposited in the fatty streaks, it becomes a plaque and here you can see the plaque is developing between the media and intima. Now, the lumen is not compromised and it is okay. As the plaque size increases, okay, more and more calcium and more fats get deposited, your plaque size is increasing. And this is called positive remodeling. Why it is called positive remodeling? Because this plaque is extending outwards between the media and intima. Your lumen is not compromised. This is increasing place. This is called positive remodeling. Next step is the negative remodeling. As the plaque size increases, it slowly encroaches the luminal. From the outer aspect, now it is moving to the inner aspect and here you have the obstetric syndrome. So, until this part, you may not have any symptom. Only when cause obstruction inside the lumen, you get an external angina. So, you have a lot around 20 to 30 years before this becomes obstruction. And all your invasive tests will be normal because everything is maintained, your flow is maintained and there is a positive remodulating. But when the obstruction in the lumen happens, your invasive test will become abnormal and patient becomes symptomatic. Here, when the plaque ruptures a thrombus formation, there is complete obstruction of the lumen. Here, the patient will have an acute MI, and if you don't treat it, you have a death from coronary artery disease. This is how a coronary artery disease progress inside the vessel. So, here you can see at the age of 30, late 30s or early 40s, you can see 40 streaks happening. Then slowly develops into a plaque. By the time of 60 years, you will have a plaque which is waiting to rupture. This is the normal progress of coronary artery disease. When I started my practice way back in 2000, we used to have patients at 70 years less coming for coronary artery disease, but nowadays it is around 30 to 40 years young fit individual. The saddest part is the coronary artery disease are very extensive and the vessel lumen is more narrower, so any intervention is of no use. So, another important thing inside the coronary arteries is you have to know what is critical occlusion and what is total occlusion, that is white thrombus and red thrombus. Here this is the obstructive part, okay, but the lumen is patent. So, you have a non-ST MI. But if a thrombus develops, it becomes a transmural infarct and you have a ST segment elevated myocardial infarction. So, this is the STMI and this is when it is a subendocardial. Subendocardial part is always prone to injury, which is called the non-STMI, and if your myocardium is fully involved where there is total occlusion, it becomes an STMI. So far we are looking about the coronary arteries. Now coming to the veins, we have three cardiac veins which accompanies the three great arteries, that is the great cardiac vein, middle cardiac vein and the small cardiac vein. All these three veins form a common channel and drain into the coronary sinus. This is the coronary sinus which drains into the right atrium. This is the coronary sinus which drains into the right atrium. Apart from that, you have anterior cardiac vein, Thebesian vein and bulbous cordis vein which drains into the right atrium directly without into the coronary sinus. They can drain directly. And another important terminology in anatomy is going to be your dominance. Which branch gives to the posterior interventricular artery is going to be the dominant branch. Usually it comes from the right coronary artery and it is called the right dominant circulation. When it comes from the left circumflex and this goes into the posterior interventricular groove, it is called the left dominant circulation. Normally it is right dominant in 80% of the population, left dominant in 10% of the population, but another 10% you have the posterior interventricular artery coming from both circulation, then it is called codominant circulation. Now coming to the arrangement of the coronary artery into the epicardium, myocardium and the and the endocardium. Epicardial vessels, this is the epicardium, is basically the conduction vessel, and your intramyocardium is basically where most of the resistance comes into it, and subendocardium is like your end vessels. The arrangement is very similar to a screwdriver. This is the largest part which is like the epicardial vessel where your flow only going to be there, and your myocardium is going to be the inner part which is inside the green part which is the muscular artery where the most of the resistance, it has to come out from that and give the blood to the subendocardial part. So, most of the resistance is going to be in this part, and this is the subendocardial part which is our like end organs. Okay, this is go inside the endocardium. So, what is this endocardial epicardial relationship? So, this is the epicardium and blood vessel has to go through the muscle and supply the subendocardial part. So, when the muscle contracts, when this muscle contracts, your muscular artery is going to be squeezed and there is going to be no blood flow to the endocardial part. But when the diastole, when the ventricle relax, this squeezing effect is not there. Here you can see the vessel dilated and supplies the subendocardial part. So, the most important part in this relationship is during systole, the coronaries doesn't receive blood supply, and during diastole, it receives the blood supply. And coming to the most important part, which is really interesting, is the physiology of the coronary arteries. Normal coronary blood flow is about 0.6 to 0.8 ml per gram per minute. That is roughly about 250 ml per minute, which accounts for 5% of the cardiac output. But when you do exercise, this increases about 4 times, that is 1000 ml. It has the capacity to increase its flow at least 4 times during exercise. Coming to the oxygen consumption, in a normal beating heart, it is about 8 ml per minute per 100 gram. Okay. In an arrested heart, when you give cardioplegia, your oxygen consumption is less than 2 ml per minute per 100 gram. But when you do severe exercise, heavy exercise, the myocardial oxygen consumption is increased 10 times. Okay. It is about 70 ml per minute per 100 gram. So, in normal blood flow increases 4 times with the exercise, but the oxygen consumption is increasing 10 times. And to add to wolves, the oxygen extraction is already maximum. Already 75% of oxygen is extracted. So, bottom line of these two slides is you have to increase the supply. Already the extraction is maximum. So, any event happens, you have to increase the supply. So, here you are seeing that the oxygen consumption is increasing 10 times, but the blood flow is increasing only 4 times. How the coronary circulation is going to compensate for this disparity? That is what coronary physiology is all about. So, how it is going to happen? There are 3 ways it can happen. The lumen can modify. Either it can vasodilate or vasoconstrict. Your mean aortic pressure, which is the gradient which is required to push the blood into the coronary artery. And finally, you have to adjust your oxygen demand supply, which is the most critical part for maintaining the coronary circulation. So, how this is going to happen? It can be mechanical. Okay, mechanically the size of the coronary artery might increase or decrease, and your metabolic and the hormonal component like adenosine, your carbon dioxide, oxygen, potassium, and paracrine hormones like histamine, bradykinin all come into picture. And finally, although the neural effect is not much, but becomes very significant when you have an extensive coronary artery disease. Coming to mechanical factors, here there are 3 components. One is the phasic flow, what happens in systole and diastole. And another important thing is autoregulation of blood flow. What happens with various pressure head, or what is the coronary blood flow with the varying degree of blood pressure. And what happens to various region of the heart. For example, what is the blood flow in the basal region and what is the blood flow in the apical region. Coming to the phasic flow. Okay, this is the normal aortic pressure line. Here, this is the x-axis is the aortic pressure and y-axis is the cardiac cycle, which shows the systole, and this is the systole. The dotted line is the systole and this is the diastole. Here you can see the coronary blood flow is hardly 40 ml in the systole, but increased to 100 ml in the diastole. So, your coronary receives blood flow in the diastole. This is only the left coronary. But let us see what happens in the right coronary. Right coronary, you can see it receives blood flow in both systole and diastole. In fact, in systole it receives little higher blood flow. And here you can see the left coronary, the blood flow is about 100 ml, but here it is maximum is 15 ml. Because right ventricle requires red supply, it is maintained. But most important thing is it receives blood flow both in systole and diastole. I will explain this diagram better when I am showing the coronary filling pressure. So, in phasic flow, the coronary receives more blood supply in the diastole. That point you have to take into the brain. What is autoregulation of coronary blood flow? It is nothing but the ability of the heart to maintain constant coronary blood flow in spite of various changes in the perfusion pressure. Okay, let me explain. You have the coronary flow on the y-axis and the coronary pressure which is on the x-axis. Okay, here you can see the coronary flow and this is the pressure. From a pressure of about 30 to 120, you can see a constant coronary flow, which is about 1.5 ml per minute. So much variation of pressure is there, but the coronary flow is maintained. When it goes below 25, here you can see the coronary flow coming down, and when it goes above 120, the coronary flow is increased. Here you have maximum vasodilatation and here you have maximum vasoconstriction. And what is your fractional reserve? you can see the coronary blood flow increasing from 1.5 ml to 5 ml per minute. So, almost 4 times the flow can increase. That is called the coronary fractional reserve. And what happens to this reserve when your heart is stressed? Here you can see the autoregulated range, and this is the maximum vasodilatation. The reserve is almost 4 times, it is 5 liters. And this is the zero pressure where there is no coronary blood flow. Okay, now you decrease your maximum. This is the maximum flow you said. This is the maximum dilatation. When you decrease your maximum flow, like when there is an left ventricular hypertrophy or a microvascular disease, your tachycardia or a volume load is there which stresses the heart, your maximum flow comes down. From 5 ml, it has come to 3 ml now. And you have increased your resting flow by stress, okay, which happens with your increased heart rate, your blood pressure increase, your contractility and your anemia. Here, your basal flow is increased from 1 to almost 1.5. So, you have decreased your maximal flow and you are increased your basal flow. So, then your reserve has come down by almost 50%. You understand, by making the heart work hard, you increase your basal flow as well as decrease your maximum flow. So, your reserve is come down. So, your basal flow is high, your maximum flow has come down, your reserve is reduced. From a reserve which was about 4 times, now the reserve is hardly 2 times. Another important thing is you have to look at the autoregulation in the epicardial and the endocardial coronary artery. This is the epicardial vessel, this is the myocardial vessel and this is the endocardial vessel. This is normal coronaries, and when a coronary disease happen, what will happen? And resistance 1, this is a R1, R1 is here, this is R1 and resistance 2 is inside the myocardial vessel and R3 is the, this part is the R3 is the subendocardial resistance. And you can see the arrow mark size is increasing progressively. Here you can see the arrow mark size is increasing progressively. That means the resistance in the subendocardial part is going to be very, very high as the disease sets in. Before that there is not much resistance, but as the disease sets in the intramyocardial vessels, the resistance is going to be more. Okay, now look at the diagram. The yellow one is the subepicardium. Here you can see it is at 20 millimeter of mercury. Here you can see it starts above the endocardium, but below the endocardium it ends. The perfusion pressure is way below what happens in the endocardium. Here you can see the heart is stressed up, so the perfusion pressure required to perfuse the subendocardium is at a higher level, and which is more so when a coronary artery disease comes in. You need a higher pressure to perfuse the subendocardium. Here you can see the perfusion pressure. The autoregulated range is slightly higher for the subendocardium and the gap widens as the disease sets in. And another important thing is the regional variation of the blood supply. For example, what happened in the apical part and what happens in the basal part. Okay. Now we have extensive nuclear imaging and PET scan which shows the exact blood supply to each part of the heart. So here you can see the relative stress is 95% at the base but less than 60% at the apex. And here you can see the coronary fractional reserve which is at 1.2 at the base and 0.8 at the apex. And here you can see the capacity, fractional capacity, which is about 26 to 29 in the base but 41% at the apex. Now coming to the last important part in physiology, which is the metabolic factor, which happens with the metabolism at that particular muscles, and it can produce, here the endothelium will be a major player and it can produce either vasodilator or vasoconstrictor depending upon the stress it undergoes. The various vasodilators, adenosine is the most important coronary vasodilator. When the heart is pumping too much, it releases a lot of adenosine, so the coronaries are dilated. Another important thing is potassium channel, your acidosis, hypercarbia, hypoxia and prostaglandins. And the various vasoconstrictors which might be released is thromboxane A2, endothelin, prostacyclin high, bradykinin and angiotensin II. These are all the various hormones and paracrine hormones which plays a major role in the subendocardial part. And as I said, neural it is very difficult to assess the response, what happens with the vasoconstrictor and inotrope, and what happens to the coronary blood flow with sympathetic supply. But theoretically, yes, epicardial contains lot of alpha receptors. By giving stimulates alpha receptor, you cause vasoconstriction. And endocardial vessels contain lot of beta receptors, beta 2, and they cause vasodilatation. The parasympathetic effect is very little, but if at all, end result is going to be vasodilatation. These are all with normal coronary artery. But if an endothelial dysfunction or moderate atherosclerosis or severe atherosclerosis happen, any sympathetic stimulation will lead to vasoconstriction. With coronary artery disease, if you are going to give an inotrope or a vasoconstrictor, it is going to cause more vasoconstriction of the coronary artery. But at the same time, you have to maintain the perfusion pressure to get the blood into the epicardial and the myocardial artery. So it's a fine balance of maintaining the pressure and your vasoconstriction. You should not increase a vasoconstrictor beyond a limit where it causes the endocardial vessels or epicardial vessels. And another important concept which is required is the coronary filling pressure. Okay, as I said, pressure plays a major role in epicardial supply. Here you can see the red one is the aortic pressure. This is the systole and this is the diastole. In the systole, this is the left ventricular pressure tracing. In the systole, there is no gradient between the aorta and the left ventricle. So, there is no gradient. There is no gradient to push the blood into the coronary artery. That is the reason the systole doesn't receive any blood flow. But what happens in the diastole? Your LVEDP is low, the aortic diastolic pressure is somewhere between 80 to 90. So, there is a gradient of around 60 to 70 which can push the blood into the coronary arteries. That is the reason coronary artery receives the blood in the diastole. But what happens in right ventricle? The right ventricle systolic pressure is hardly 30 to 40 millimeter of mercury and the diastolic pressure is around 3 to 4 millimeter of mercury. So, there is a gradient both in systole as well as diastole. That is the reason right coronary receives blood both in systole as well as diastole. And coronary vascular resistance. The major vascular resistance is going to be into the muscular vessel. This is the epicardial vessel which is a conduction vessel which is like the green. And the most of the resistance comes from the muscular artery which is bound to get squeezed when the heart contracts. Here the heart contracts and the resistance is going to be very more. Here you can see the maximum resistance occurs in the intramyocardial coronary artery between 100 to 300 micrometers in diameter. And normally this contributes to 95% of the resistance. Epicardial contributes only to 5% of the resistance. And your epicardial vessel is flow sensitive. You have to take this picture very nicely. This is flow sensitive. This is epicardial part which is flow sensitive. And your myocardial part, this is pressure sensitive. And the endocardial part is metabolic sensitive where your metabolic mediators come into picture. Here this part you have to maintain the pressure and this part should be free of coronary artery disease. These are the three major regulators of coronary flow. And coming to the concept of coronary flow reserve, as I said, the coronary flow can increase 4 times to overcome the demand which is happening with the stress or with exercise. But if a patient develops a coronary artery stenosis and the stenosis is between 40 to 80%, up to 80%, as I said earlier, there will be no symptom. But beyond 80%, the reserve drastically comes down and the symptom of angina comes in when the patient goes for an exertion. Your demand exceeds what then required. Okay, the supply is going to be less, your demand is going to be more, and there is no way you can increase your blood flow because already artery is stenosed. There comes the symptom. And this coronary flow reserve becomes very important when you have an epicardial stenosis or a microvascular disease. This is a normal blood flow. Here you can see the coronary flow reserve increased to 4 times. When you have a compromise in supply with an epicardial stenosis, here you can see the reserve is altered. And similarly, when the epicardial is normal but you have a diffuse disease which affects the myocardium and endocardium, again the response is not there. So, even if you have epicardial disease or a microvascular disease, your reserve is altered. And coming to the various drugs which acts on the coronary circulation. Per se, only few drugs like nitroglycerin can cause coronary vasodilatation directly. But various drugs can alter the cardiac grid, which will affect the coronary supply indirectly. For example, if the heart rate is high, your diastolic filling time is going to come down, your coronary circulation is going to be altered. By producing slow heart rate by beta blocker, you decrease the heart rate and increase your diastolic filling time, and your coronary circulation is going to go up. Similarly with preload, if you reduce the preload, the stress on the heart will come down. This can happen with a vasodilator like nitroglycerin or a diuretic. It will reduce the volume work of the left ventricle. So, your demand comes down and your coronary circulation is increased. And another important thing is you have to increase your afterload to maintain a pressure head. Okay, you give a phenylephrine, you increase your pressure, but you have to be very, very careful when you give a vasoconstrictor. If a patient is on coronary artery disease, although it maintains a pressure head, your coronary circulation may be compromised. So, it requires a delicate balance between maintaining a pressure and causing a coronary vasoconstriction. And with increased contractility, your muscle is going to contract vigorously, your myocardial vessels is going to struggle, and the endocardium is prone to be ischemic. So, a little bit of reduced contractility is very, very important to maintain the coronary circulation, which can happen with beta blocker or your volatile anesthetics. Now, so far we were looking at normal anatomy of the coronary arteries. Now, let us look at some major abnormal anatomy of the coronary artery. ALCAPA is nothing but anomalous left coronary artery coming from PA. So, since left is coming from the PA, you have a dilated right coronary, and here you can see the left coronary artery coming from PA, that is the PA. Because the left coronary receives the deoxygenated blood from the PA, the right coronary artery has to supply the entire left ventricle. It is dilating and supplying the entire left ventricle. And another important thing is coronary arteries are arteries. Now, aneurysm doesn't happen only in aorta, it can happen in the LAD also, any coronary artery. This is a aneurysm, small saccular aneurysm which happened in the LAD, and here you can see a small stent which lead to an aneurysm formation of an LAD. Here you can see a small aneurysm of the LAD which happened with the stent placement of the LAD. Here you can see the small saccular aneurysm. And aneurysm, the size can be even bigger than aortic aneurysm. This is a right coronary artery aneurysm. Here you can see the right ostial injection. Here you can see the aneurysm being so big. It is very similar to an aortic aneurysm. We all thought it is an aortic aneurysm, but here you can see the left is normal and the PDA is filled retrogradely because the right has no flow, and this is the huge aneurysm, and here you can see the right atrial appendage. This was opened and it was closed with the patch. Okay, that aneurysm sac was closed with the patch, and here you can see the patch closure of the aneurysm. And another important thing is single coronary artery. Here you can see the with the left coronary aortic sinus injection, you can see all the three vessels coming from the left. These are the most dangerous condition, because if plaque rupture happens in this one vessel, all the three major vessels can be compromised. And another case we had all the three vessels coming from the right aortic sinus. Here the right aortic sinus, you can see the LAD, you can see the RCA, and you can see the circumflex, and there is no left coronary artery coming from the left aortic sinus. And coming to the clinical application, this is nothing but ischemic preconditioning. He has occluded the LAD, and here you can see the ST changes happening. Your PAs are high and your apical part is not moving. Your PA is high and arrhythmias are setting in. This is basically ischemic preconditioning. Here what the surgeon does is, he will occlude the LAD for 3 to 4 minutes and see what happens to the ECG and the echocardiogram, whether the heart moves normal or not. Basically what he is trying to do is, he occlude 3 minutes and makes the heart adjusted. With further insult, you can overcome. See, for example, he is adjusting the heart to withstand the insult which is caused by ischemia. The same patient, once he releases the proximal part, here you can see the heart beating normally and the ECG come back to normal. Here he is opening the coronary arteries and he is putting a shunt across the coronary artery. So the distal part receives, here this is the small shunt which is put from the proximal part to the distal part. So the blood supply to the distal part is maintained. So your heart was beating normally and your ST has returned back to normal. Another important thing is what is ischemia, injury and infarction. In ischemia, you have T wave inversion and ST depression. In injury, it is more progressive, your ST elevation will be there. And in infarction, you have a pathological Q wave happening. Coming to the clinical application of coronary sinus, normally in cardiac surgery to protect the heart, we give cardioplegia to the coronary arteries. But when the coronary artery is diseased or you are not able to deliver the cardioplegia like in aortic valve disease or severe aortic stenosis, the cardioplegia may not reach the left ventricle. In that case, what we do is retrogradely you put a cannula into the coronary sinus and give the cardioplegia so your left ventricle is protected. And as I said earlier, the heart has the maximum oxygen extraction. So your oxygen content will be very low. And coronary sinus oxygen is supposed to be the lowest in the body. And coronary sinus, you pace a lead for LV pacing as well as electrophysiological studies. Sometimes they do a coronary sinus occlusion to increase the coronary artery blood flow. And whenever a coronary sinus is dilated, you look for an abnormality called left-sided superior vena cava, which is one of the most common congenital anomalies which is generally missed. Here you can see the coronary sinus and here you can see the coronary sinus. Through the coronary sinus, through the anterior cardiac vein, your left ventricle is paced. This is the right atrial wire and the temporary wire which comes from the femoral vein to the right ventricle. This type of biventricular pacing, you can pace the ventricle, right ventricle as well as the left ventricle. This type of biventricular pacing is very important when there is an end stage heart failure. You can pace the right ventricle as well as the left ventricle. So you have a atrial biventricular pacing. And another important concept is the ratio of blood flow to the epicardium to the endocardium, which is called as the endocardial viability ratio. If the ratio is less than 0.7, it is associated with subendocardial ischemia. Here you have two terminology. One is the tension time index, another one is the diastolic pressure time index. The diastolic pressure time index is nothing but the your diastolic time into the coronary perfusion pressure, which is the diastolic pressure minus the left ventricular end diastolic pressure. Here the diastolic pressure index is nothing but the coronary perfusion pressure into your diastolic time. Your tension time index nothing but the your mean systolic blood pressure into your ejection time. This tension time index is basically demand and the diastolic pressure time is basically supply. So with this ratio, you know which is great. Your supply is affected or your demand is altered. And whenever coronary artery has some disease, for example an LAD has a disease, the circumflex and the right coronary artery try to compensate and overcome it. So whenever there is a lesion, this coronary artery gets collateral between the right and the left coronary artery gets opened up. Not only within the coronary artery there are collaterals, with extra coronary artery also the collaterals can happen. This includes vasa vasorum of the aorta and the pulmonary artery, internal thoracic artery, your bronchial arteries and your phrenic arteries. Okay. Whenever a vessel is occluded, this channels will open up. Here you can see LAD is totally blocked, but here you can see the LAD is filling up from the right. LAD is blocked, but you can see a lesion. LAD is filling from the right circulation. Similarly, you can see this is a normal left circulation, but you can see the posterior descending artery coming from the left. And because your right is completely blocked, here is the right circulation, nothing is there. There is a temporary pacing wire here. Because right is compensated, the patient went into heart block and your pacing wire is been put. Another important concept which you have to understand is the coronary steal. Here you can see the coronary artery is having a plaque and the blood supply to this part is compensated. This is the ischemic myocardium, this is the normal myocardium. So your blood supply to the ischemic part is reduced, but what happened is, as the plaque is there, as the obstruction happens, your collateral opens up and your blood flow to the ischemic part is maintained because your collateral is open. But if you give a vasodilator doesn't know which is collateral and which is normal vessel. So it vasodilates both. So what happens if you give vasodilator? The normal coronary artery will dilate more and increase the blood supply to the normal part, and the ischemic part blood supply comes down. Here you can see, by giving a vasodilator, your ischemic supply is altered and your normal blood supply is increased. The collateral vasodilatation is much lesser than the normal vasodilatation. So now coming to the perioperative period. Normally the oxygen demand and supply maintains a good linear relationship. But if the demand increases and the supply is less, your curve shifted to the right and ischemia sets in. But what is very important? What is the first change which happens with ischemia? Your left ventricular end-diastolic pressure goes up. So that's the reason your PA picks up the ischemia earlier. Your volume goes up. So your ventricular parameters will be altered and the compliance come down. You can see the regional wall motion regional wall motion abnormality sets in and your ejection fraction comes down. So all these features can be picked up by the echocardiogram, and then only the ST changes happen. So a good 5 to 10 minutes will be lost if you wait for the ST changes to happen. As you allow the ST changes to prolong, ischemia to prolong, you have a congestive cardiac failure and cardiogenic shock sets in. So your demand supply is going to be altered and ischemia sets in. So what are the various factors which in the perioperative period going to cause the ischemia? Your tachycardia, hypotension, hypertension, and lot of the inflammatory medias which are released during the surgical trauma. The timing of tachycardia and hypotension is very important. For example, the patient has a normal ECG. Suddenly the heart rate goes to 120 and ST changes happening. So you can understand that it is a tachycardia which causes the ischemic changes. So you have to control the heart rate. If normal ECG is there, there is an hypotension or a blood loss and then ECG changes happen. That means the hypotension is cause for the ischemia. So get the pressure up, your ECG will revert back to normal. But there is a normal ECG, ST changes or depression, ST depression or elevation happen, then hypotension and tachycardia happen. That is where your ischemia is going to be very dangerous. And one of the most important thing is you have to prevent the pressor response to laryngoscopy and intubation. That is the most crucial period where ischemia can happen. So what are the various hemodynamic changes can happen? This is a stable hemodynamics with myocardial ischemia. Here you can see the blood pressure is normal, or if it is slightly high, your filling pressure is normal. And this is an ideal situation. If any event happen, you can start a small dose of nitroglycerin. Just hold on till the surgery is over. Your blood pressure is high, your heart rate is high, your filling pressure is high. Obviously, most of the time the patient will be awake. So here you have to increase the depth of anesthesia. Sometimes the same scenario can happen with your fluid overload, or sometimes when you give a vasopressor bolus. In that case, you have to restrict your volume, go with vasodilators and take a beta blocker to reduce the pressure. Here you have a tachycardia, hypotension, but your filling pressure is low. This obviously happens with hypovolemia. So infuse volume or give a Trendelenburg position. Finally, coming to the most worst scenario, your heart rate is high, your blood pressure is low, your filling pressure is high. That means the patient has developed ischemia and there is low cardiac output. Here, you have to start an inotrope, put on a mechanical device to overcome the ischemic period. To summarize, okay, these are the take-home message. The blood flow to the heart occurs during diastole. So diastole is very important for coronary circulation. And most important thing is, coronary blood flow is determined by local oxygen demand and supply. The vascular endothelium is the final common pathway for controlling the vasomotor tone. And when anesthetizing the patient with coronary artery disease, the most important goal is maintain the perfusion pressure and avoid tachycardia. And this is one of the famous character in Mahabharata, King Karna. He is known for donating whatever he has. He can even sacrifice. He sacrifices Kavasa Kundala, which is used to protect his life. He even sacrificed that. And even after sacrificing, when an arrow was passed in the heart, he cannot be killed because he has done lot of good things in life. So he has to sacrifice his good deeds also to be killed. In fact, he even sacrificed his good deed to be killed. That is the greatness of King Karna. Similarly, coronary circulation, the whole life, okay, it gives blood supply to the heart for the heart to function. But what is very important is the coronary artery does not receive blood when it is stressed. The most important point you have to understand from coronary circulation is that it does not receive blood when the heart is in systole. That means when the heart is stressed, although it gives blood supply to the whole body during systole, it does not receive blood during systole. When the heart is relaxed, that is diastole, it receives its blood supply. That means the more you relax, more blood supply comes to heart. The same thing applies for you in life. The more you stress, the more you struggle. The more you relax, more work you can do. That is very, very important, and coronary circulation teaches you that. Thank you.